Thank you so much, and thank you for inviting me, and thank you for your warm words. And I'm happy to be here every year again and again. I was asked to talk about the dark side of TAVR in younger patients. Well, I didn't want to put the dark side in our in the title, but yeah, I'm going to talk about, as Roxana said, the bad, the good, the bad, and the ugly. So I'm going to say just a few words. What do we know about TAVR in low risk and younger patients, which we don't really know a lot. Then the darker issues, and then a few words about my personal opinion. So you know those papers, and I'm not going to go through it, but it has shown that there is no inferiority in TAVR for low-risk patients, even in some superiority. And those are slides that are running again and again, and you know it. And it has been shown even borderline with younger patients than 74, with superiority of hemodynamics, mainly with the supraannular valve and the PPM as well. And the key message was that the partner at the Medtronic core valve studies validated the relative safety and efficacy of TAVR versus surgery. But they excluded quite a lot of groups in the TAVR society, like the bicuspid, the pure AI, the high-risk anatomy, the alternative access, TAVR in TAVR, valve in valve, etc., but younger patient, of course. So what are the dark sides of younger patient? Well, one is the durability of the valve. The second is the life expectancy of the patient. And the bottom of those two is the need for repeatability, like a TAVR in TAVR or explant. Another problem is the coronary access, and of course the high prevalence relatively of bicuspid aortic valve. We're talking about the valve durability. Well, who is more durable? This one or this one? I got no clue. I don't know if anybody really knows. And you know what the reason is? That historically, for most surgical studies, have associated structural valve deterioration with the need for reoperation, without any specific modality to show or to just adjust exactly which one and what is the failure. Given that the reoperation does not necessarily imply SVD and vice versa, one would expect a systematic, dramatic underestimation of the incidence of SVD in those groups, namely the surgical valves. And this is especially true in those elderly patients that most of them were refused surgery, and that's why we had very low numbers. They didn't have the definition that Danny Dvir have done early in, like 6 years ago, or the definition of the European Society by David Capadino 7 years ago, and definitely not the VARC 1, 2, and 3 that Roxana was part of it many times, that was published lastly by Philippe Généraux. All we have is the follow-up of the TAVR trials and the Edwards trial. We have the notion, and I'm not going to repeat the slides that George gave you before about the notion and the etc. And we have the Resilia that we are all waiting for to see the true clinical results. So the main issue with young patients is that unlike the older one, the life expectancy of the patient is unlike in the older one. The life expectancy of the valve is the rate limiting factor of the procedure, of the event. Because if this is the life expectancy of 80 years old and this is of 65 years old, you understand that this guy is going to need at least another one valve. And at least another valve could be in surgery, but we know the results by Fukuhara and other 7 studies that show that the outcome is very, very poor. And then Uri Landes and John Webb has published all the registry with TAV in TAV with excellent results, which are very similar to valve in valve. Well, is it true? I mean, when it was published, I'll just remind you, all we knew is to measure the distance from the annulus to the coronaries. And we said, well, there is a nice distance, there is nice sinuses, it's good, you can have a TAVR in TAVR. We didn't know then those letters, the VTC and the VTA, and then we had this publication that taught us that a VTA, which is smaller than 2 millimeters, endangers a patient's life by coronary obstruction. And we learned the new skirt, the neo-skirt, that will close his coronary in the next valve unless we'll put it deep enough or with the lower frame valve. Now, I think I've shown this. This was just those days in a patient that I did TAVR in TAVR. And we didn't know then to measure the distance, the VTA and the VTC. So just in case, we did a protection with like a chimney-like, just in case, okay? I want you to have a look. This is not the lecture, but I want you to look at that again. And this is something that I see again and again. TAVR in TAVR, the S3 behaves completely different. Did you see that it is going up? You take the last 50 cases of TAVR in TAVR that have done in your center, have a look and measure it, and you will see it again and again. They behave differently. And I'm showing you this because here I'm keeping the stent in, but I see that it's perfect. We take it out, never mind, and we give last injection, and you can see that just to make sure, you can see the left coronary, you can see the right coronary, right? And I was happy. But 3 days later, the patient collapsed and died. And I'm telling you all this because TAVR in TAVR, with all the measurements, is not as secured as we thought before. And now we are having another application by Winnie Buffett in order to plan before the first TAVR how the second TAVR with another valve is going to look like, including all the valves that we have today, but we're not going to probably have tomorrow. And the other problem is the prevalence, the pretty high prevalence of coronary artery disease in those patients, and the difficulty to access the coronary in some of them with all, the tricks. And it is so important because 74% of European centers that are performing primary PCI do not have TAVR program. And if they not have TAVR program, they don't really know what's coronary alignment. They don't know the difference between Allegra and Evolute. And it translates into the result that in ST post-TAVR, the prior TAVR is associated with a much longer door-to-balloon time and a much worse outcome and mortality in those patients. And the last point is, the high incidence of bicuspid. Now, bicuspid, the measurement is different and the implantation is different because we have anchoring difficulty, etc., just the difference between riding bicycles or tricycles. So Yoon and Raj Makkar have shown us that the outcome can be beautiful, but it can be beautiful as long as you select the patient. Again, select the patient to those that don't have the huge raphe calcification. So my last words or my take-home message, look, those are the guidelines of the European, those are the guidelines of the ACC, which are more generous, okay? But as my father used to say, the dog barks and the cover moves on. Or in other words, this is 2 years ago. Like 50% of people in the United States that are having aortic stenosis at the age of 65 are going to TAVR. And 90% over the age of 65 are going to TAVR. So if you're asking me, the dark side of TAVR to young patient is wrong anatomical and clinical selection, because life expectancy outweighs age, and multidisciplinary valve team consultation should be for all patients, not just patients for TAVR. A patient is going to surgery, he should have a heart team as well. We should decide on one lifetime sternotomy, and regardless of age, always think that a second valve might be needed. The lifetime risk outweighs immediate procedural risk, and estimated risk should consider not only the short but the long term, like the TAVR in TAVR, the TAVR in SAVR, the cumulative risk of high-risk therapy, including the aortic root enlargement or replacement, the explant, the TAVR in SAVR, anticoagulation, etc. I think that bicuspid aortic valve is not a contraindication, but we should select the patient in which it's appropriate. Until proven otherwise, I don't know if the durability of the TAVR valves is different from those of surgical, but we need a clear rational anatomy and data-driven approach that can be applied in any individual case. And we need to work with the surgeons to define whether we go next, because neither TAVI nor surgery is going to look like within 10 years. And I do thank you very much for your attention.
Thank you very much, Arik, for your fantastic talk. It was one of the most comprehensive sort of approaches to the whole thing that I've ever heard. And I'm sure that my co-chair, another old friend since 1984, so I'm getting older, and I'm thinking how old I am. John Kanakakis might have a comment on what Arik has suggested.
Okay, thank you very much for the excellent presentation. How can you define the young patients below 60, below 70, below 75? What's the age of young, as we talk about young population?
Look, I think that every country has a kind of consensus, you know, like a silent agreement with the surgeons. You know, in Israel, that, by the way, I told him we have done much more than that last year. We have done like 3,000 TAVR approach, and I'm saying this because we are doing much, much more than the health basket allows us to do. And this is because kind of a silent, you know, a status quo with the surgeons. But, you know, the status quo says about above the age of 70 or below. Below has got to have a very good reason. And a very good reason is either post-CABG or post-AVR, etc., etc. But our whole problem, let's be honest, are two things. One is the patient that a long time understands more and more and comes with more information and insists, I want the less invasive procedure. And my duty is to be honest and tell him, yeah, but this is not better for you, just like we had in the coronaries. And the second one is the professional reliability of all of us, because all of us wants to do more and more. Yeah. But you have to be honest with your profession. And I truly think that until proven otherwise, a younger patient should not go to TAVR, but not because of the durability, but because of a lifelong expectation of this patient until we have a really durable valve. But I have a double problem, because if you are asking me, I would not exclude even that the patient of 60 years old, I'm not saying this is right, but it's something to think of, should get a TAVR procedure at the age of 60, and then he should have a surgery at the age of 70, and then he could have a TAVR, valve in valve at the age of 80. I mean, everything is possible. I don't have the answer right now, but
I think what you said, that we have to plan for one sternostomy during the duration of life. That's the right thing, and we have to decide what is the right time to be done. First, second, third, whatever it is. And I think possibly the youngest age for the sternotomy is the better.
Definitely.
But it's something that we have to consider.
And regarding this, and you know, there were many questions in the New York valve. What is the most important advance that should be done now? Look, the pacemaker rate is a single digit. The PVL leak, you know, it's around 0 for moderate or more, etc., etc. The profile is 14 French. You know, there is maybe 5% of the population that cannot get a 14 French. And definitely by far the most important unmet need, and I would put all the money in it, is to extend the durability of the valve. I'd like to have now a valve that is, its durability is 20 years, no matter what. And I'll put all the eggs in the same basket there.
So where is your prophecy? So you think that the Resilia tissue, the Resilia valves, you don't know?
Look, I'm working with Edwards on, you know, it's in Israel. All the research, the development. So I'm working there. I have no.
Yeah, and another question on the age. So you have a, let's say, a cutoff value of 70 in Israel, when you, or it's
like
because in case we have a 75.
It's like a consensus.
Yeah.
It's somewhere between the American and the European.
So,
Professor.
So we have the two panelists, Dr. Perreas and Dr. Pattakos.
So wonderful lecture, Professor. Every time I hear you speak, I like what you say more and more. I think myself and Dr. Perreas were going to get you an honorary degree of cardiac surgeon for the very fair and balanced approach that you gave. What I would like to say is that in my viewpoint, I think that the young patient should be considered the patient who's going to need a second valve. And this is most of our patients. So the issue of young patient is, you know, debate, TAVR, SAVR. Whatever the age may be, if you tell me that this patient has a life expectancy of 5, 6, 7 years, I would say there's almost no debate, and if it can be done transfemoral, they should get a transfemoral TAVR. When they're going to need a second valve, I think that's where the debate starts. We had a patient who came back to us, had an initial evolute at age 86, came to us at age 92, requiring a redo operation, could not have a redo TAVR, and needed open surgery at the tender age of 92. So I agree with Professor Michalis, who said that if you're going to have one sternotomy, I think what makes most sense is to have the sternotomy be the first operation and the transcatheter operations happen later. I have a lecture coming up later in this wonderful meeting we're having, and I'm going to show the fact that TAVR explantation carries a mortality risk of around 15 to 20%. So the best series of events we can have is a series of events where there's no TAVR explantation occurring, probably.
Yeah, you're absolutely right, but I think two things. One, when this old patient got his first TAVR, none of us was really aware of the issue of a need for a TAVR in TAVR. It doesn't happen to again. Second, if you are talking about a younger patient, this is exactly what I was trying to emphasize. A patient-tailored therapy. I look at a patient who is 70 years old. If he is not suitable for a future TAVR in TAVR, no way. I'm serious. I'll tell him, look, you can do TAVR not in my hands. Because you are definitely going to need a TAVR in TAVR. I don't say one thing that runs into my mind, and this is that there is a very, very good chance that with the technology parade around TAVR that we are having, I want to sit here within 7 years and present the first case of a TAVR explant transcatheter.
I'll tell you what's the difficult thing in the US and why you see such a huge, huge thing. It's about patient preference. We can be presenting them. I've had several patients presenting them. I had a patient with bicuspid aortic valve stenosis and some aortopathy, and I felt 100% this 72-year-old woman should have surgery. The patient went with the family, flew to Florida, in Florida, from the airport, went and got a TAVR. So, by a surgeon. So what I will say to you is that the problem of this is that whatever we could say here, if not everyone doesn't follow it consistently, then the patient's preference, which is always above all, despite the fact that they could have all of the information, they will go in New York City. There are 8 centers within a few blocks of each other performing TAVR. And across the bridge, there's one that the highest, 700 TAVRs. Do we believe, and I promise you, if you look at those 700 TAVRs, I'm certain 300 of them are in the age less than 65, 100%.
But that's exactly what I emphasized before, and I said, honesty, professional honesty, this is it. You believe in it, and you have to I mean, that's our education, Jesus Christ. We're not educated just how to eat with a spoon, right?
We have to proceed. Thank you very much.
Thank you.
Thank you. It's